I forget. We're all super excited to have you present for all the counseling students on behalf of CSO. So I will give it over to you.
Sure. And thank you for having me. Like I said before, I'm always happy to talk about EMDR because that is my life passion. I I started here with a quote that is part of the books that we share within the EMDR community. And I think it really talks a lot about what it is. The goal of EMDR is to achieve the most profound and comprehensive treatment effect possible in the shorter period of time while maintaining client stability within a balanced system. And I think that that talks a lot about the approach and everything else that we're going to get into. But of course, I'm going to just say a few words about myself, just so you know who I am. I'm a licensed mental health counselor. I own a group practice in Boca Raton and in Coral Springs. We probably should talk to the NOVA people because we have interns from FAU and other schools, but we don't have interns from NOVA yet. It's not something that happened. I'm a qualified supervisor for interns, and I'm a EMDR approved consultant, as well as kind of right now becoming a trainer, because like I said, it's really something that I'm very passionate about. So that's just a little bit about me, and we'll dive right into just a little bit about trauma. I know you're counseling students, so you know probably the basics of this, but I also like to cover this because I feel like it's important to cover just very basic things. And I'll also show a short video by Dr. Dan Siegel. He's a neuropsychologist and psychiatrist. Like, he has like multiple degrees. It's a very short video that I feel like I wanted to share because it's important for you guys to have it, especially to be able to share it with other people. So, you know, research shows that after disaster, the brain and the body changes. There's the whole idea of the triune brain model, which talks about the brainstem, the limbic system, and the neocortex, which are the parts of the brain that are the most impacted after trauma happens. And then the idea that our body becomes hyperactive or hyper aroused. And I don't mind sharing this presentation. If you want, Samantha, I'll send it over after we complete, so everybody have a copy of this, so you can have some of those links. I actually linked here a link to the hyperarousal versus hyperarousal, because a lot of the times people focus on the hyperarousal symptoms, like being anxious, being angry, all the hyper reactions. That's what most people are used to. And they really don't think about the hypoarousal, which is the more numb, lack of energy, disinterest, isolation. Those are all part of being impacted by trauma, and those are the symptoms. So sometimes people feel like, oh, I don't have the other things of being on alert, but they don't recognize that they also have been impacted by trauma if they have the other symptoms. And really, EMDR talks a lot about the fact that it's not so much what happened to you, but how you perceived what happened to you. Because we can sit in a car together, me and any of you in a car, going through a really terrible car accident, front impact, same impact basically, and I could be screaming out of my lungs, oh my God, what happened, without having any type of regulation. And the person next to me can be like, oh wow, I can't believe this happened, let me call 911, let me see what's happening here, and being really on top of everything. So the perception of what happened to us really impacts the way we're gonna then have symptoms to the trauma, and of course, depending on what we had prior to this. So let's see how we do with stop share, and then I'm gonna try to reshare as quickly as possible to show you the video. And
one of the most rewarding experiences for me is to study brain science and apply it to experience of parents. And the hand model of the brain that I use to teach parents is very easy.
Can you turn the volume up a little on your end? Is it really quiet for everyone, or just me?
Is it for everyone? Because on my side it's high. I can try to share it with my other computer. If
put your fingers over the top. This is a very...
Oh, that was a little bit better.
That was a little bit better, yeah.
Was it? Okay, so let's try again.
Model of the brain, and when we can actually see in front of us what's going on in the brain, then we can change what the brain does. So let me walk you through very basically what happens in this brain and the structures in it. And it goes like this. Spinal cord comes up, representing the wrist, and then you have coming up into the skull, the brain stem and the limbic area, which work together to help regulate arousal and your emotions and the way you have a fight, flight, freeze response. These are below the cortex, the limbic and brainstem areas, and the cortex is this higher part of the brain that allows us to perceive the outside world, to think and reason. And this frontmost part of the brain, right behind your forehead, so the person's oriented like this, is actually the part that regulates the subcortical, limbic, and brainstem areas. This regulation is very important because sometimes we can have all sorts of things happen in our life. We're tired, we're exhausted, someone pushes a particular emotional button, and we can flip our lids. So rather than being tuned in and connected and balanced and flexible, we can lose all of that flexibility, even lose moral reasoning, and act in ways that are terrifying to others, including our children. Now, you can actually bring yourself back online and come back to the high road and make a repair with your child, and that's important to explain to them. And you can also use this hand model of the brain to explain to children, even as young as 5 and 6, how to understand when their emotions are rising up from the brainstem and limbic areas here, and how it's overriding the prefrontal area and making it so they may be about to flip their lids. So I've had kids come tell me that they're about to go flip their lids and they need a break. They need a timeout. By even just naming that, they can tame it. And that's the power of using the hand model for ourselves.
I just stopped
and our
it.
children
Opa.
to help us all make sense.
Sorry
of
about
what
that.
goes on in the emotional communication that
What
we
just
have
happened?
in the course of day-to-day life.
I don't know where it went. That's funny. But what? Sorry about that. It just disappeared from my screen and I can't even find it nowhere. Can you still hear that chatter in the background? Oh, here it is.
All right, I think we're going to get.
Sorry about that. So let me share the presentation again. Share screen. So again, going back to what he talks about, it's just a really good way of explaining, when you flip your lid, right? Like when you're so hyper aroused, and what happens for people who experience trauma, a lot of the times is that the lid doesn't really close. It stays pretty open, and it's really hard to go back to being grounded, being within the window of tolerance, and it's important to remember that. So I just like to give a little bit of background before we dive right into. I'm going to skip this because I want to make sure that we have time. It's just basically, and I'll send this to you, all of you. It just describes the difference between the top down and the bottom up. I'll review a little bit of it in the next slide. And it shows where the bottom up techniques that are in therapy are more related to the limbic system and the emotional state versus the ones that are more top down, which relate more to the thinking, to the cognitive, and all of that, which I separated it here a little bit. And I wanted you to know, as far as why EMDR, which is one of the bottom up approaches, seem to be more efficient in being able to do things quicker. It can still be done through TFCBT, CBT, and other top-down models, but part of the struggles is that when we do CBT approaches or any top-down model, is that you want the thinking brain to be active. And when somebody is traumatized, a lot of the times their ability to be more cognitive is difficult, and even the request to have them think about things in a cognitive way can be very, very challenging. So that's just a little bit to cover that part of things. EMDR stands for eye movement desensitization and reprocessing, as you probably know. It's a method of psychotherapy that helps healing from trauma and other distressing life experiences. It's been widely researched. Francine Shapiro developed it actually in the 1980s initially as EMD without the R. It was just a way of doing eye movement desensitization. She was walking in the park as she was talking to a client, and she noticed that the success of the therapy was much more beneficial and started discovering the journey of bilateral stimulation, because walking is actually bilateral stimulation as well. I tell all my clients, no matter if they decide to do EMDR or not, and that's something that you can use in your work with your clients, bilateral stimulation as a way of grounding. So I teach them either the butterfly tap, which is one of the most common bilateral stimulation approaches that we use. I teach them just to tap their thighs. If you my hands were on my thighs and I would be doing that. You can do it with your feet, so just bilaterally moving from one side to another. If you want to do it really subtly, you can kind of like put your arms, like that, and then you just tap with your fingers. People who have road rage, I tell them hold the wheel and just tap on the wheel, so it helps you regulate. Any type of this kind of activities that does bilateral stimulation, what happens is that physiologically, your brain, both the right hemisphere and the left hemisphere, have to be activated when you do bilateral stimulation. And that's what allows for what we call in EMDR dual attention. So you're here, you're talking to me, you're grounded with me because we're doing the bilateral stimulation, but we're basically also accessing the subconscious part of the brain. And that's where the work happens. Because a lot of the times with trauma, because it is stored in a non-adaptive way, so the way we may react to it, it's going to be different, meaning I may get a trigger by not even realizing that I'm getting triggers. And I like to explain it to clients in a very simplistic way, in the sense that you all know Pavlov's experiment with the dogs, right? And they were able to create up to 5 triggers or 5 connotations for the dog that were created. Human beings have the infinite ability to make connotations, to make triggers connected to each other. So if I was sitting in my office and something terrible happened to me here, and my brain at that moment picked up on my water bottle, it picked up on my blue pen, and it picked up on the mouse for the computer, right? That's what my brain at that moment, when something happened to me, linked to my trauma. Now my bottle, my pen, and my mouse for the computer are linked to my trauma. Now, I wouldn't think that those things are going to be linked to my trauma, right? There's no reason for me. And even if I'm resilient, and even if I'm getting through it, and either with therapy or on my own, I got through what happened to me, I move on with life. But it could be even a year after. I go to somebody's office and they have a very similar water bottle, or I look at somebody's mouse of their computer, and I can get triggered, and I wouldn't even have the realization that that's what's happening. At that moment, when that happens to me, wherever I'm at, if I pick up on 3 new triggers, and it could be any one of the 5 senses, it could be the chair I'm sitting on, it could be the colors of the wall, it could be an item around the room, it could be a taste that I had in my mouth because I just had a mint gum before this all started. So now the new triggers from the new experience are linked to the 3 triggers from the first experience. And I know it sounds almost surreal to think, what, like those 3 things will be now linked to 3 completely unrelated things, and they're going to trigger my trauma? Yes. And that unfortunately can continue happening. So again, I get triggered, new things in that area can be linked, and now the brain is it's all on the same neuropath, and it's all going to be linked to one another. And unfortunately, that's why we flipped the lid too, because, and I'll give an example of a client that I worked with. I worked with a therapist, actually. She was a therapist for 26 years. She was a woman in her 50s, adult kid, like great, like happy in her career, happy in her marriage, happy in every area that she had in her life. Yet her nephew died in a very tragic car accident. She actually was at the scene. It disheveled her so much that she had to take a leave of absence from work and wasn't able to function anymore. She was barely waking up in the morning. She was barely able to function on her daily living. And she came to me desperate, saying, like, I'm sad about my nephew dying, but I don't understand. Like, I went through so much in life. I have coping skills. I cannot like get out of this. And we explored a little bit, and the negative cognition, which I'll discuss a little bit in a minute, the negative cognition she had is like, I have no control. I'm out of control because of what happened. Like, she saw what happened at the scene, but there was nothing she could do. He died on impact. We dived into her history, and she's like, no, but I worked on stuff, and there's really nothing from the past. But EMDR tells you to do a really good history. So we did. And we found a memory from 3 years old that she remembered, but totally didn't think about all these years, when she was molested when she was 3 years old. The memory of the molestation from 3 years old had the same negative cognition. I have no control. When we worked on that memory, it took us a little bit of time to work through that memory. It wasn't fast, but once we worked on that memory, she was able to go back to work. We didn't even work on the nephew tragic accident yet. We did that down the road. But as soon as we worked on the first memory that triggered everything, she was able to return back to work. She was able to return to daily functioning. She continued working with me to desensitize other stuff from her memory. But we had to go back then, even so she was so resistant to it, because she was like, what does that have anything to do with anything? I was 3, like I got over it. I even got to see this cousin at events, and I said, let's just give it a try. And it was just so amazing to see how that was changing for her. It was a life-changing, basically. And EMDR is based on a 3-pronged approach, meaning it's all about the past events that happened to you, the present triggers that are happening at this moment right now, and it's all about the future template, meaning imagining how life is going to look like, what could potentially be some triggers that are going to still happen in your life, in order to work on desensitizing those, because they may link to either other memories or another layer of the same memory. Because we have to remember, one memory can have different layers of trauma, right? Because if I take the example from earlier of a car accident, I can have the feeling that I'm not safe, right? I can have the feeling that I can't trust anybody, right? Driving on the road. I can have the feeling that I have no control. I can have multiple layers as far as the negative belief that I hold about myself because of what happened to me. So through the EMDR process, you want to make sure to work both on the past, on the present, and on the future. And it's really, really important. Sometimes people go to do EMDR, and sadly, some therapists do not follow the protocol. And as I'm sure you all know, if it's a research-based approach, in order for it to be the most efficient, you have to follow the protocol. And sometimes it can get very overwhelming because it's a lot of steps and then it's a lot of things that you have to cover. But if you just follow the protocol and then get more training and get more consultation hours, you'll be able to master that it becomes very fluid. But at the same time, like if I open my drawer right here, that's where I have my stuff for EMDR. I still use my handout from my training from years ago just as something that is there. So if I want to, I can go back to it, but it's good to have it. So this way you're following the model to be able to provide the best care for your clients. Those therapists who decide to do something, of their own, unfortunately, a lot of the times they can create this situation where people didn't get to do the future template. And then because of not doing the future template, things come back, right? Because once you work on something with the EMDR, it's not supposed to come back, meaning the negative emotions associated without control, right? The triggers are not supposed to come back. Once you work on something, that is it. The difference between doing EMDR, and that's why I'm so passionate about it, because I did talk therapy and CBT for a really long time before. It's healing. It's not just teaching your clients how to cope with whatever it is that is going on in their life. You're really healing them from whatever it is. And I'm talking to you people who, totally got rid of PTSD related symptoms. I'm talking to you about people who had severe panic attacks, who got off medications to be able to live their life normally, getting rid of their anxiety, getting rid of depression. Of course, there's many different clients and it doesn't work the same way for everybody, but there's been huge success in all of that for many of my clients. The EMDR process, it basically uses the natural way to heal from a traumatic experience. Just like when we get hit, and get an injury, like a cut in our arm, then our body knows what it needs to do in order to heal that space, right? It'll send whatever oxygen or whatever vitamins to that part of your body to be able to heal. The brain has the capacity to heal from emotional trauma. What sometimes happens because of the traumatic event and because the system then becomes paralyzed in some ways, then it doesn't have the accessibility to the adaptive information. And it's almost like if you put something that happened to you that you stored adaptively, so it's like a file cabinet, right? And in the file cabinet, you'll store it alphabetically and kind of like organize everything good. But then if you went through a traumatic event and your system is hyper aroused, then what happened? It's like the A was stored in the Z, the B was stored in C, and so forth. It's a little bit of a mess, and it's hard for you to actually recall what happened to you. Sometimes a lot of people at the beginning of the process would not be able to even tell you the beginning, middle, end. It'll be very jumbled up. They'll have flashbacks of information. They'll have partial of the information. And then at the end of the process, not only they're able to tell you what happened with beginning, middle, end, they also are able to do that without having an uncontrollable emotional response. Now, not to say we're taking away the emotions, right? We cannot get rid of the memories itself. We cannot change what happened to a person, but we can change the way they feel about it, right? So the stress response is natural in process. After the response of a traumatic event, some of the images, thoughts, sensations, feelings, they remain and they hunt you because you're going from fight to flight to freeze, sometimes constantly just being stuck in fight or flight or freeze without being able to at all coming back to a window of tolerance. And that can be very challenging. Teaching about the window of tolerance, I didn't include it here, but I can definitely include a link to it. There's a link on the web, on the internet about the window of tolerance, and just teaching clients sometimes that that's what's happening to you. You're just outside of the window of tolerance. They kind of like, oh my God, so I'm not going crazy. Because I always feel like I go, get anxious and then I can come back to being okay. And that's just because, and we all go out of the window of tolerance. Which one of us didn't have the experience of about to leave the house to be on time for class or for work, and we can't find our keys, or we can't find our car or our cell phone, maybe sometimes even the cell phone in your hand, and you can't find it as you're leaving the house, right? And you're running around trying to find your phone. That's going outside of window of tolerance. But for people who are not right now responding to trauma and they have average amount of abilities to ground, then, oh my God, where's my phone? Finding it, getting in the car, maybe I'll take a few deep breaths, I'll relax, I'm coming back to the window of tolerance, I'm driving, I'm going to work. Versus another person who's right now triggered by their trauma, they will be still possibly hyperventilating, not being able to leave the house, or getting out of the house but driving really carelessly because their mind is not even fully there. So those are huge differences that happen. And with the EMDR process, you're able to teach the brain how to reprocess the memories, how to desensitize what happened to you. It's basically just activating the natural healing process to basically clear some of the triggers and what activates your brain so much, and then you're able to go back to normal functioning, basically. It is recommended to do 90 minutes long. A lot of providers like myself, I'm an insurance provider. Insurance does not cover more than 60 minutes. So we try to do it within the 60 minutes. And then if not, we make accommodation to work with the clients on figuring out how to do that. For the majority part, if you plan your time well, you will be able to conduct with most people a 60-minute and it will be as efficient. With some people, most definitely not. But there's many components as to how to evaluate. I want to stop right here to see if there's any questions, so then I can continue. Any questions so far? Okay. So like I mentioned before, it's an EMDR is a research-based approach, and it has 8 phases. And I know that sounds like a lot, but the first few are basically what you do with your clients anyway. History and treatment planning, right? We all do that. That's part of what we do. And I didn't include it here, but that's definitely part of it. It's the therapeutic alliance. Having therapeutic alliance, we know that regardless of what methodology you use, it's one of the most important components of the therapeutic process. That's where you build that therapeutic alliance. When it goes into phase 2, it talks about preparation. Preparation is basically teaching the clients a bunch of resources. Breathing technique, meditation, there's different ego state work that exists with doing this work. Safe place, safe person, resourcing of all kinds. Really, I tell my clients, imagine I'm giving you a bag that is empty now. Then I'm going to load you with a bunch of things, and you're going to put in the bag what you like and works for you, and you're going to put outside of the bag what doesn't work for you. It's okay, because we're different people, so different things are going to work for different people. What I do, and it's now recommended by EMDR, is I combine both of those phases together. Meaning, a lot of the times when somebody comes into your office and start telling you about what happened to them, if there is complex trauma, they're going to become dysregulated. They might start crying, they might start hyperventilating, they might just be, you'll see them sitting like that, really uncomfortable. Then what I would do is right away, what I talked to you in the beginning, I say, will it be okay for me to teach you something to see if it's easier for you to share with me what happened? And normally they'll say yes, and I'll just say, can you start tapping your feet for me bilaterally? Just tap your feet from one side to another. And as you talk to me, just continue doing that. When I was back in the office, I also used tappers, which is just vibration tools that they hold in their hand or they can put underneath their thighs. And I would just have them, would it be okay to put it under your thighs? And they would just put there, not recognize that it's there. And again, it's that dual attention. We're able to regulate them, that they're able to then share information a little bit more comfortably, a little bit more regulation. So I combine both, meaning as soon as I see something is happening with the client, as soon as I'm seeing that physiologically there's some reaction, reading facial cues, body posture, speech, if I'm noticing anything, I teach them right on the spot something. And that is part of what we call like the buy-in, right? Because they're kind of like hyper and they're barely able to speak. And then I teach them this and they're, I'll talk about it. That's really interesting. So that whole process can take anywhere from 2 to 3 sessions, which is, our normal assessment with therapy. And it can take way longer than that, depending on the complexity of the trauma, depending on dissociation. And dissociation is a big piece that was not discussed a lot in the past when it comes to EMDR, but is heavily discussed now because they recognize that, excuse me, a lot of people have dissociation and then it ends up getting misdiagnosed as either borderline personality disorders or even schizophrenia or bipolar, just people dissociating. And mind you, we all dissociate, okay? Meaning we all have different ego states. I have the ego state of me right now, sitting in front of you, talking to you about EMDR. I have an ego state of mine that is very silly and childlike when I interact with my 5 and 6-year-old. I definitely am not the same person that is sitting here with you talking right now. I have the part of me that is the wife. I have the part of me that volunteers. Every part of me sometimes can be a form of dissociation for people who have complex trauma, and they develop that as a tool to survive. And I can talk about that a whole day, so I'm not going to elaborate on that. But if you all decided that, if any of you decided that they want to get some EMDR training, then it will be discussed, and it's something that you need to continue just getting trained. In general, I say, I don't think in my courses at my master's level, they talked about dissociation except about DID during psychopathology class. If they talk more than that in Nova, kudos to Nova. But mostly from the interns that I work with, it's barely talked about. It's not a topic that we talk about so much in grad school. Make sure to get some training about dissociation so you learn to recognize it in your clients, regardless if you're going to be EMDR trained or not. Because sometimes the client can just doze off and stare into space. That could be a form of dissociation. Somebody can say that they see things through fog and they become very anxious when that happens. That could be a form of dissociation. And again, it's not DID. It's not the clinical dissociation severity, but it's just, if I was a little kid, and when I was a little kid, my dad used to beat up my mom really heavily. And for me, I used to listen to music and disconnect completely during those episodes. That's a form of dissociation, okay? So that's, all of that is explored during the history and treatment planning. You wanna know, you can still work with the client if they dissociate, but you wanna know the severity of dissociation. You wanna know how to ground them. You wanna know how to bring them back to their adult self. So all of that is explored during phases 1 and 2. And like I said, if it's a single event trauma, which, right, so events in EMDR can be explored through single event trauma, like shooting, a car accident, drowning, many different events that just happened, but there was no priors. The person was pretty stable in their life. Nothing major happened. They don't suffer from anxiety. As I didn't cover that in the beginning, but I was very involved, and I still am, in the recovery of the Parkland shooting and the survivors from the shooting. And I worked with a lot of the families, the kids, the teachers, and we used a specific EMDR protocol for them. And with some clients that didn't have anything before, 2 to 3 clients of sessions of an hour and a half and they were fine. And I was amazed. I would follow up like a week after, are you still okay? Like, I'm making sure here that this was not just a thing that happened in session. And they would be like, nah, yeah, I'm back to everything is fine. Everything is great. And I'd be like, okay. And for others, I'm still seeing some until today, right? Because there was some other things that were prior in their system as far as what they have to work through. So of course, again, we're talking 2 to 3 sessions to 3 years later. So the continuum could be very, very large. Phases 3 to 7 are basically the session itself, okay, when you actually get to reprocessing. So phases 3, 4, 5, and 6. In the assessment, and I'm gonna skip and we'll go back to the video after. That's very wordy. It's just basically a blog that I wrote about this, and I have it on my website, and I can actually attach the link to it. I just included it here because I want to send it to you guys so you have that. You really don't have to read this. I'm not going to read this, but part of phases 1 and 2 I already talked about. In phases 3 and on, what happens in every EMDR session, you ask the client, as you go back to this memory and what happened to you, when you think back on it, think about an image to represent the worst part about what happened. And mind you, it could be the craziest thing of how the mind can go with that too. If I go back to the example I gave you about the car accident, the worst part about my accident could be the moment of impact. It could be the fact that I was texting right before it happened. It could be 3 months later when I got the hospital bill because I have no insurance and I got like $25,000 in bills now that I have to pay. Everybody, worst part about it could be very, very different. So identifying that. And then as you identify the worst part about it, you ask the client, what is the negative belief that you currently, right now, hold about yourself because of what happened? So you identify that. That's the negative cognition. And a lot of the times it goes into responsibility, safety, or control. Those are the most common areas. And within that falls many, many different statements. But the accident, I'm not safe. I'm not in control, right? Those are the different things that can come up and variations of that. Once you identify that, then you identify the positive cognition. So what would you rather think about yourself now at the end of this process? What is the positive belief you would like to feel about yourself, think about yourself when we finish this process and you think about this memory? And then, okay, so I identified I'm not safe. It's over, I'm safe now. And that's the thing with trauma, right? Even so you know here that it's over and I'm safe now, I may feel here emotionally that it's not over. I feel like I'm still inside, in the car during the car accident, in the classroom during the shooting, whatever it is that happened to you. So this is not something they believe at the beginning of the process. And those are our measurements. So that's the first measurement we take. It's called the VOC. And you ask the client, now that we have identified the positive cognition, from 1, when it's completely untrue, to 7, it's completely true, how true does the statement feels to you now? So it's over, I'm safe now. And they may initially say, oh, it's 7, I know I'm safe now. Okay, is this answer from your head or from your heart? Is this an emotional? And then they're like, well, most of the time I feel like I'm still at the scene. Okay, so give me a number from 1 to 7. Where do you feel like it is? And they rate that. After they rate that, then the next level, you have them identify how disturbing does the memory feel from 0 to 10. That's our second measurement. 0, it doesn't provoke no emotions. 2, 10, it provokes uncontrollable emotions. So it's very disturbing. And even here, it's an interesting process because when I think back on the shooting, even myself, even so I wasn't there, but I worked with enough people, I'm never going to feel okay about what happened with MSD, right? None of us will ever feel like this was okay. But now when I talk about it, it doesn't provoke an emotional response that is uncontrollable. It doesn't trigger me in a way that I am, shivering or crying or, my voice is shaking. It doesn't happen anymore. For people that went through the process of EMDR, that's what was able to happen. For myself, I can share with you, and I'm sharing it because you're going to be therapists one day yourself, and vicarious trauma, and it's a real thing. About after 3 months of doing EMDR therapy with clients and hearing the stories of the classrooms, I started having nightmares. I had a vivid image as if I was there. It was the most insane thing ever because I had images of everything that they told me. And I had to go seek EMDR myself to clear some of it because they would tell me, and all of a sudden I would smell the gunshot, the residue. I would smell it. And it was the weirdest thing ever. I was like, I wasn't there. How is that possible? But again, right? Trauma is not necessarily what happened to you, is how you perceived it. And I heard it so many times that my brain created a visual for it, right? It was easy for the brain to create a visual because I heard it so many times. So I had to get EMDR myself to clear so I will be able to provide therapy because otherwise I was getting triggered in session when people would tell me what happened. So once you identify how disturbing the memory is to the client, you then ask them to see if there's any emotions and feelings that they can recognize there is attached to it. They list that, and then you have them do a body scan. So scan your body from head to toe and note if there's any part of your body that feels uncomfortable, that feels that disturbance, and they identify that through that process as well. Then you go to the sensitization, which is the eye movement, right? So back when I was in my office, I would either use the eye movement, and they call it two ships passing in the night. So you don't sit in front of your client, you sit on a variation on the side. If I do it now virtually, I basically make myself disappear from the screen and I move my fingers. I actually have a backdrop that, so it's not too distracting. I have a white backdrop that I do my fingers. There's also some electronic versions of it. There's music. I use metronomes. There's many variations to how you can do bilateral stimulation because we're doing it virtually. When I was in my office, I used tappers, the vibration tools that I told you. And then you basically start the session by saying, after you did the whole assessment, then you say, okay, now I want you to take a deep breath, focus on that image, where you feel it in your body, and the statement, I'm not safe, and go with that. And then the therapeutic alliance changes significantly, and that's definitely something that you cover with your clients before you start. Because then you're not a talk therapist anymore. You don't talk. You want the client to share as little as possible in between sessions. You want them to be in the zone. So you do a set of about 40 of back and forth 40. Then you stop, you take a deep breath. Tell me what you noticed. And then they tell me whatever they noticed. There's going to be those clients who are the talkers, right? They're going to want to start telling you, in addition to what they really noticed, all these things. And then you just try very gently and say, like, just notice that. Like sometimes I have to literally interrupt them as they talk. And I just say, notice that. Because otherwise they're going into their cognition. They're telling me more from their cognition versus from the limbic system. So again, notice that. The most thing that we say is notice that, go with that, focus on that, concentrate on that. Those are the most basic things that we say over and over and over and over. If a client then becomes very stuck in a negative schema, right? And I'll give the example of the client I mentioned earlier today with the 3-year-old who was molested. Even so, she was 3, the person was 27. She had the negative self-belief that I should have done something. She was stuck in that. And even so, again, this is a 50-year-old woman, therapist, but emotionally, that was her feeling anytime she thought about that. There was something about feeling responsible. So what we have as a tool is what is called cognitive interweaves. So if somebody gets stuck on a schema that is clearly irrational, so it's not my opinion, it's not something I think, it's clearly irrational, because can a 3-year-old could have done something if she was held down by a 27-year-old? Really? He was babysitting her, they're alone at home. There's really nothing she could have done, right? Because even if she would have walked, he'll catch her. It wouldn't matter, right? So it's not my opinion. It was the reality. So I may say, I'm confused. Were you a really tall and big and strong 3 years old, right? So I'm not telling her, oh, there was nothing you can do. I'm just challenging her mind to use the adaptive information that is already there. Wait a second. I was 3. He was 27. He was big. He was strong. There was nothing I can do. So I give them like a hint. Here, use this. Like I'm giving the brain a tool that it already has. Use this to reframe everything that happened. And then sometimes that helps the process. And there's many different cognitive interweaves that are being taught. And as you become more skilled in doing it, you become, your own things that you can say. I was very scared initially, using those because you don't want to lead the client. This process, and that's partially why I love it so much, it's so empowering because the clients get there by themselves. They don't really need us to do any of it. They do it all by themselves. We're just leading them. We give them the keywords, we give them the guidance, we help them reframe, but they really get there on their own. And sometimes clients will say at the end of the session, I'm not feeling anything. And then they come back the next week and they're saying, it's so weird, but I was around my dad who before, anytime he would say anything, I want to, jump on him and beat him up because he used to beat me up. And now I can be there and look at him and be like, wow, this poor guy, no self-control. That's so weird that I feel like this now, right? And it's like, so you're not necessarily even knowing at the end of the session how powerful the impact of the session is until they come back. And then they're like, I'm thinking differently about things. I'm looking at things in a different way. And one really good analogy that I use with clients is like, I wear, reading glasses, but if my shades instead of clear were red, right? Any of you, if you would wear red glasses, so now everything is going to look red, and it's real. For me, it's red. As long as I'm wearing the red glasses, everything is going to look red. If I take the glasses off, then I can see things for what they are. But that's my reality as long as the glasses are on. And with trauma, if you have a negative schema, a negative belief about yourself, I'm stupid. As long as you're wearing that schema of I'm stupid, it's enough that somebody says, this doesn't really make sense. You calling me stupid? Right? And that happens so many times in relationships, in intimate relationships. We really, really see the negative schemas that we have about ourselves because we can think, I'm not good looking or I'm ugly. And my husband can say, this dress doesn't look so great on you. Are you saying I'm fat? Right? But right away it goes there and your husband may be completely confused as to what just happened. And that's what happens because the schema is there. And part of what happened with the EMDR process is that we help people take those shades off. We help them take the red shade off so they can see themselves for who they really are versus the schema that they developed either at a young age or later in your life, depending on what their life events are. Once the clients get to a 0 as far as the level of disturbance and their evoke is 7, then you can install. Okay, so install, it's almost like save as in the computer. It's basically the same process. We help the brain save whatever positive cognition we identified. We can even do it at about 0 to 1, at about 6 to 7, meaning sometimes, like with the Parkland shooting survivors, with rape victims, it happens a lot of the times, even with domestic abuse, many different cases, people just have a difficulty cognitively saying, this doesn't disturb me. Even so it doesn't provoke the trigger, they're still saying it's never going to be okay. So it's never going to be a 0 that I lost my son in the shooting, right? It's never going to be okay. So that's okay. If that's what it is, it's more a cognitive, it's not an emotional. Then we can even install with a 1, as long as the vote is high. And you can install it at a 6, as normally what happened after one set of installation, it increased to a 7 by itself. And if it doesn't, then you just ask the question of like, what's preventing the 6 to become a 7? You want to know if it's, again, if there's a clinical issue that you still have to process, or it's just a cognitive thing of an idea of, I can never feel okay about what happened and stuff like that. Then you do it twice, basically. And then the third measure is then the body scan, because at the end of the process, you then ask the client, scan your body again. And then you see all of a sudden, yeah, I'm not feeling that pressure in my shoulders anymore, or my stomach doesn't hurt when I think about it anymore, or whatever it is that they identified originally is all of a sudden gone. Now, if it's still there, it means that we're not done yet. And sometimes you know how it is, partially because maybe they're a people pleaser and they want to just tell you what you want to hear, right? And that's why we have the different measurements. Then you say, okay, what do you feel? Oh, I feel this, I don't know, I can't even identify it, but I feel weird in my stomach. Okay, just notice that. And then again, we start processing from that place to just see what are we missing. And it could be a feeder memory, meaning it's not even the memory we're working on, but it's something on the same path of I'm not safe or whatever was the negative cognition. So then when we say to the client, okay, I see like this is something that is a feeder memory, it's an outside memory to what we were working on. Will it be okay for us to put it in a box and work on this memory outside of this session next time we meet? And then you do an exercise that is called the container exercise. And I can teach you that quickly too, because it's something you can use with your clients currently as well. It's really, really effective, even though it might sound like really, it's so simple, but it works very effectively. So you have them imagine, close their eyes, imagine a container. Actually, let's do it kind of like experientially for a minute, because it's really, really short. Everybody closes your eyes for a second. Take a deep inhale through your nose. Hold it for a moment, and let it out through your mouth. I want you to think about a minor annoyance, not something big, just something that annoys you a little bit that you prefer really not thinking about. And then once you have that in mind, I want you to imagine a container. And the container could really be anything you want, from a cardboard box to a Tupperware to a safe in the bank. Whatever you want it to be, it could be. Any size, any shape, any material, any color, anything you want it to be. Just, it has to have some kind of a lid or closure. And it can have a lock on it, it can have a chain on it, it could have a padlock, it could have fingerprinting, whatever you want. It's your container. And then I want you to imagine opening in the container. And you're going to put that annoyance right now, in your case, just put that annoyance inside that box. Whatever thought, feelings, sensations, images that link to this, you're going to put inside the box. And then when you're done doing that, you're going to imagine closing the container. And again, in any way that you want, you're going to imagine closing it. And then you're going to imagine either putting it away where it's comfortable for you. You can imagine giving it to me. You can imagine throwing it at the beach with a huge weight on it, so it's not close to you whatsoever. Really do it however feels comfortable for you. And when you're done that, you can just take a deep breath and come back to the room. Okay, and then you tell the clients, from this moment on, anytime something wants to pop out of that box, you're going to tell yourself, I can't go there. I'm going to go there when I meet Luna the next time. And it works really, really well. Now, if somebody has an issue with, no, it continues coming up, then you say, okay, open another box, put portion of what's flooding that box in another box. So they can have many containers to do that, okay? So I will have them take that memory, put it in a separate box, and then all of a sudden they'll be able to desensitize the other memory completely. Then, like I said, the body scan is part of it. And then the closure is the following session now. After we finish the memory, I'm going to say, I want to take you back to the memory we worked on the last time. If you don't mind, just take a deep breath, close your eyes, bring up the memory again. The worst part about it, does it provoke any disturbance from 0 to 10? For the most part, they'll come back with a 0. Sometimes they'll come back with a higher. And then you'll have to process it again and make sure that it's completed. And then when it's completed, you close it, and then again, you test it out the next session. You always want to make sure. And then you do, once it's completely clear, the second session, then you ask about a future template. So imagine the possibility of ever being in, a situation like that again, and then testing the body for that. That's a future template to make sure that it really worked and everything was efficient with the process. And here I just mentioned quickly Professionals United for Parkland, because that's the nonprofit organization I'm part of because of what happened at MSD. I'm not going to give you the details about it, but if you ever want to be part of an organization that supports what happened at MSD, please reach out to us. We always look for more people to be part of the organization. But I want to show you a quick video. I think the quality of the video will be better if I share it from my other. See if it lets me. Oh no, because I'm co-host here. Okay, I'll try to share it from here. Hopefully the volume, because I know before it was a little bit of a problem. Hopefully the volume would be okay. And if not, just let me know. So this is actually, it's available on YouTube, so you can see the full version of it yourself. It's a lot of the EMDR videos that are out there are either done not so well, or they're old. On the sidebar, you actually see Jamie Marish. She's actually an amazing EMDR therapist. So from her, you can always learn anything that she does on. And this is Dr. Roger Solomon, who is one of the people who got initially trained by Francine, and I find it to be a really good video. I'll show you portions of it. Hopefully you'll hear it, and if not, you'll have to watch it on your own. So let's see.
I can't hear anything.
I can't hear anything either.
So it's giving me issues in total. You're not even hearing anything?
Nope.
Okay. Well, we don't have a lot of time anyway, so I can send it to you. It really shows the whole process and how she goes from, even if you just see like how she is here when she starts, even if you don't hear anything, you'll see when she starts the process. Oop, it went to another video. When she starts the process, you can see her head is down. She's crying. She's really having a hard time. And then when you go toward the end of the process, you'll see her looking up. You'll see her smiling. You can see it even visually how she's changing through the EMDR process. Now, Dr. Roger Solomon has been practicing EMDR for years and years and years. So, some of his language may not be the most technical one like others. So just keep that in mind. I'm going to leave room for questions. Nobody have any questions?
I was wondering, because you said with like the Parkland, like some quickly healed after a few sessions and some are still healing. So how do you determine like when you start to go back? Like, and when you need to like, or like the 3-year-old, like, you need to go way back. Like,
either way, the way to identify is you ask the clients for their worst, most recent, and the earliest memories. The suggestion is to start with the earliest memory always, because we call it the keynote memory. So, for example, I had a new client yesterday. He just lost his mother to cancer, but she got cancer 4 times altogether. And the first time was actually when he was 16. He's now 40. And he wants to work on this most recent of losing her. And I will most likely do that because it was really recent. I'll do a specific protocol for a recent event trauma. But then after we do that, just because he's really not functioning at all. So I'll help him reduce that because it's very severe and now to the point that he can't function or go to work. So I'll help him desensitize that with the most recent event protocol from EMDR. It's not the basic protocol, which is what we did with the Parkland survivors as well. We didn't use basic protocol. And then after I do that, then I'm going to go back with him to the first time she got sick. And he was actually pulled by, the principal out of class. And it's traumatic. When I had him think about it, he was like, oh my God, I haven't thought about it for years, but wow, I'm like, my chest is hurting. I said, okay, we'll go back to it after. But so when something recently happened, you want to try to process that, because almost like when we look at a client and if they have medical issues that we want to clear the medical issues first, or substance abuse. So we need to take care of the most pressing issue first, and then we can dive into the other stuff. If somebody just comes in with, and I can't tell you how many times people come in with, oh, I have anger issues. I've always been angry, or I have anxiety. I've always been anxious. Well, for the most part, babies are not born with anxiety, for the most part. They still may have some preverbal trauma and so forth, but I'm pretty confident that you were not born anxious. So something must have happened at some point, and it could be an event that happened to you. It could be your mother was just very anxious, and they kept on making comments around you that made you anxious too. So we work with whatever it is, with the big T's or with the little T's. And to tell you the truth, most of the time, the complex trauma are more the little T's, which is growing up in a home with parents who were very demanding, or growing up in a home with parents who are very anxious. And we wouldn't look at it as necessarily trauma, but it actually is, because if your parent was very helicopter parent, and they kept on saying like, here, I'll do this for you, or let me help you doing this. So you may have gotten the message that I'm not capable, or I'm not good enough. And your parents did not intend whatsoever to make you feel this way, but this is how you perceived their messages of protection. So you have to work on desensitizing those little T's, because otherwise, if you see yourself in a way that you're not capable, then most likely it's going to be very hard for you to feel like you're capable in anything in life in many times. So it's all those different things. So depending on what you present at therapy and how complex your trauma is, then we want to go on either the past if you can, and if it's too pressing, then you do the most recent, and then you go back to the past in terms of being able to clear all of it. I hope that answers your question.
It did. Thank you.
Of course. Any other questions?
I have a question.
Sure.
You mentioned at one point that you were kind of experiencing vicarious trauma working with the Parkland survivors, and how that kind of prevented you from working with them. Are there EMDR therapists that specialize in seeing therapists? Does that make sense?
I think that there's certainly, I find that your niche finds you. You know, I would say almost half of my caseload right now is therapists. It just happened. I love doing that. And my own experiences with doing therapy, and especially with everything that happened as a trauma therapist. So it just kind of happened. So yeah, it's kind of like more a word of mouth. It's not something that most people say like, oh, I'm a therapist who sees therapists. But yeah, there are some therapists who feel more comfortable working with therapists, because therapists can be challenging to work with. Yeah. So it's important as therapists to find somebody who feels comfortable working with therapists. So it'll be a question that I would ask. You know, it took me forever to find my own therapist.
Yeah.
You know, because not everybody feels comfortable working with another therapist.
Thank you.
You're welcome. Anything else before we wrap up? Well, thank you for having me. I hope you got something out of today. And if you have any questions, feel free to reach out to me.
Thank you so much, Luna. Yes, if you could send me the PowerPoint presentation, that would be awesome. And I can send it to everybody that's here today.
Sounds good.
Stop recording.